So, who is the best candidate for prostate removal for prostate cancer, or better known as prostatectomy? And what is the best approach? My guest today is one of the best, Dr. James Eastham, who is the Peter Scardino Chair in Oncology and Chief of Urology Services in the Department of Surgery at Memorial Sloan Kettering Cancer Center in New York. Dr. Eastham received his medical degree from the University of Southern California in LA. He completed his internship in general surgery and residency in UCLA and USC Medical Center. He went on to complete a fellowship at Memorial Sloan Kettering, and he never left. Dr. Eastham was an assistant and associate professor in the Department of Urology at Louisiana State University, Chevron, and Chief of Urology at Overton Brook Veterans Administration Medical Center in Louisiana. His research focus is all related to prevention and treatment of prostate cancer and has particular interest in improving oncologic and quality of life outcomes after prostatectomy. Dr. Eastham is a gem. We spoke a little bit as to who is, most surgeons are currently using the tool, the robotic tool to remove the prostate. Who's not the right candidate for a robotic surgery that actually needs old school open surgery, an open prostatectomy? And we talked a little bit about his lifestyle. How does he take care? I'm always curious, aren't you? How do you take care, Dr. So-and-so? How do you take care of your health? What do you do? What are your practices? We had a little conversation about that. Please enjoy this amazing conversation on all things related to prostatectomy, prostate surgery, and prostate cancer with Dr. James Eastham. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. Welcome to the Dr. Gio Prostate Podcast. This is your host, Dr. Gio. I was going to say Dr. Gio Espinoza. I never do. It kind of just came out. But this is your host, Dr. Gio, interested in helping you optimize your prostate health and prostate cancer. Even if you don't have a prostate, how can you live better despite that removal of your prostate, which I'm sure we're going to talk about in a minute as well? And how do you live better after such a diagnosis? We see it all the time. Thank you for being here. I have a great pleasure, as you know, from the bio, from the history of having Dr. James Eastham, who I've been an admirer and maybe even a stalker from far, although we're not that far from each other. Dr. Eastham, I can't tell you what a pleasure it is to have you on my podcast. You know, if I would have known that this podcast, I would have the best of the best come on, and most of them say, yeah, I'll be on, and I get to talk to you guys. I would have done this 10 years ago, not 2 years ago. So one of the best things is that I get to speak to people like you on this platform. So thanks so much for being on.
It's a pleasure to be here. I think for many of your guests, certainly for me, it's a pleasure to chat with you. You've done some outstanding work, continue to do so, and perhaps outside what is considered to be of traditional medicine. But I think that combined with traditional medicine can really enhance patients' quality of life. So I follow you as well, maybe not stalking. I wouldn't use that word, but certainly all the work that you've done to try to help patients in their overall well-being, their overall health, not just from a prostate health, prostate cancer standpoint. So I look forward to chatting with you.
Thank you. Look, for decades now, I've had patients. Well, who's your doc? Dr. Eastham. First of all, sometimes they come to me. So I wear two hats at NYU. One is, hey, I have, this stage prostate cancer. What do I do from a natural and lifestyle perspective? I want to reduce the risk of a recurrence. I'm on ADT now. What do I do to reduce the risk of the side effects of that? Or I'm on active surveillance, and God knows I don't want my prostate treated with anything. What do I do? That's one hat. The other hat is prostate cancer navigator. So, hey, I went to see Dr. So-and-so. What do you think I should do? Both from a natural perspective, but also from a medical perspective. What else is out there? Maybe they're not telling me anything. I went to see so-and-so. Obviously, I'm a proponent of second opinions, third opinions. Not when they go to see Dr. Eastham. They go to see Dr. Eastham. I say, look, I tell you, I love I'm super biased towards my institution. Dr. Tanasia, Lepore, Bill Huang, Wysock. They're amazing people and amazing physicians. Only a few times where I say you shouldn't look anywhere else. So you're seeing Dr. Eastham. You actually in very good hands, unbiased. He doesn't, because sometimes patients think, well, do they have kids in college? They're doing it for money and all the kinds of cynical things that I believe are just cynical. I said, you don't have to worry about those things with Dr. Eastham, and you're going to be very happy. If you're going to do surgery, you're going to be very happy with him. You don't have to go anywhere else. So you're one of the few, Dr. Eastham, where I'm able to say
please call me James. I tell all my patients to call me that. So I like to keep it, not as
formal,
doctor patient, but get it more on the we're sitting in the same chairs looking at each other in the eyes. So
I appreciate, I typically do. I had Eric Klein on, and I had a hard time calling him Eric. I mean, this is my senior person. Eric Klein, been around forever. It's like if I have Patrick Walsh, I can't call him Patrick. You're not quite as
I mean, I can't call him that either. He's Dr. Walsh.
Exactly. So I put it, and Eric's like, just Gio, please, just call me Eric. I said, okay. So I have you up there as well. All right, James, we'll do James. So you are excellent with your patients. I think, I spoke to a faculty member of yours at Sloan before a day. And he was talking about, how he communicates with patients and how he learned to do that and so forth. But you have a way, and again, I never shadowed you with your patients, but they all say, God, is he a good surgeon? Because sometimes people think, well, if you have great bedside manners and you're a great communicator, there's no way you could be a good surgeon. Like, you need to sacrifice one to be I said, he is a fabulous surgeon. So what's that about? How are you able to connect so well with your patients being a surgeon?
I try to put myself in their position. And I understand that they're going through a very difficult time, and they're trying to sort through multiple decisions, which, if you think about them all at once, can get very confusing. So I try to explain things in a way that's more stepwise than trying to think of everything at once, and taking time. I try not to rush through anything. As I say, I sit down, and most importantly, I try to listen. I try to give the patient the opportunity to let me know what their main concerns are. And it becomes, I do most of the talking, but I try to listen to see what's most important to this person, especially when I talk about side effects of treatment. Because sometimes patients come in and they say, I just want to live as long as possible, cut the thing out, and then I'll accept everything. And it's like, well, wait, there are other options, and they work very well. And, even though I am a surgeon, surgery is not for everybody. And so it's really just, maybe it's back when I was younger, I was a tutor, and I sort of tried to learn how to explain things in a simpler way, perhaps. I try never to use jargon, but I don't know. I didn't do anything special. I'm happy that my patients are pleased with me, but I think it's time talking with them, not down to them, and listening. I think that's the most important thing that we can do as clinicians. It's not giving a lecture. It's really an interaction to try to help the person come to a decision that's good for them, not good for me.
That is amazing. Not yet that common. I mean, I know a few that have that approach, and not yet that common, ironically. And it's not taught in medical school for sure.
That is true.
That may be part of the issue. I might have, if I had to guess how many prostatectomies you've done, I'm going to ballpark it. I know I'm going to be off. 6,000?
Probably a little less than that.
A little less?
I don't want to do more and more prostatectomies. I do typically 2 a day. I don't want to go into multiple rooms. I don't want to have to rush. I don't want to cut corners.
Right.
So I do 2 a day, 2 or 3 days a week. So I've done over the years probably about 5,000. But could I do more? Sure. But I don't think it's in anyone's best interest. Mine certainly,
Right.
working late, that's not going to help me. And from a patient's perspective, do you really want to be the fourth surgery that, and it's a delicate operation. Do you really want someone who's, worn out and tired being the fourth patient of the day on their surgery list? So rarely I'll do 3 in a day, but mostly it's 2. And I don't have to do every single prostatectomy in the world. And so that's how I balance my practice.
You said something so key and important. If you're the patient, you may not want to be that fourth patient, right? I always say, try to make your appointments as early as possible. You don't want to be that 25th patient on the list. And,
right.
These are humans. Maybe robots will replace you at some point in the future, but the way the world technology is going, but these are humans skipping lunch, hungry, low blood sugar, all these things that occur just from kind of being on that, going from room to room and seeing patients. I love the approach. I love the approach, and I love your mentality on that. It reminds me of a recent interview with Dr. Peter Scardino, who was chair of the department there in urology for a while. And in my mind, so I'm a little bit of a historian, and I love the history of urology. I even read Hugh Hampton's book, autobiography. First surgeon, at Hopkins to perform a prostatectomy. Amazing book. So I love that kind of stuff. Scardino for me is, Mount Rushmore in terms of urologists and surgeons, urologic oncologist. In terms of history, papers, he said something very interesting, and it goes back to I'm not interested in doing more than 2 a day. He says something very interesting. He says, look, I wrote 400, I forgot the exact, 400 papers, 480 papers. And he said, I'm very happy with my accomplishments, and I think hopefully I've impacted enough of our students to do well in this field. But, maybe I could have done 300. And maybe, I don't know, maybe my quality of life would have been better. He says, I'm fine, but maybe, I had some relationships issues. Maybe I had his second marriage, and maybe it would, he either implied or said, maybe I would not have had a second marriage. Who knows? Maybe I would have been fine with 300 papers. And that's, when do you say this is enough? People with money, with a lot of money, they're worth X. When is it enough that now you can say, look, I'm content? So I really admire and love what you said.
Yeah, I think, I have the good fortune of, as you know, training with, I still call him Dr. Scardino, Peter.
Exactly.
During my fellowship when he was at Baylor, and certainly agree with you that he was a great surgeon. He's an outstanding communicator. His patients, loved him. And so I probably should have mentioned that. I had the good fortune of working with someone who had traits that I admire. And And so hopefully that helped mold me into what I am today. But yeah, I mean, the problem we have, at least I had as well, is you don't realize you're on the treadmill of churning out papers and trying to be academically productive until it's already happened.
Mm.
And, he can look back and reflect on, did I really need to do that much?
Mm.
Should I have taken a little bit less workload during my career, still be very successful? He would have been, of course, but sometimes we don't realize it until we've already done it. And so that's one of the things I try to, when I chat with fellows, it's, you don't have to be on every single panel. If you're doing good work, they'll invite you back. You don't have to be afraid that, if you don't say yes to everything, that you'll never be invited back. And, take time with your family. And, your kids only grow up once. And you have to, if you're going to be in academics, you have to do some academic work, but perhaps you don't have to be as clinically busy. And finding that balance, and it's tough, but finding the balance where you don't neglect, your patients, they come first, your family, well, they come first too, and your academic career, which is sort of 1B. That doesn't have to be 24/7. And trying to find what it is that makes your life, your overall well-being, something that's good for you. And I'm not sure if any of us ever do that. We go spend a little bit too much time at work or spend a little bit too much time one thing or another, but at least getting folks to think about it, rather than just saying, oh, I've got to focus on my job, because if I don't, I won't get that abstract published.
What grade would you give yourself with work-life balance throughout your career? A, a B, a B
I'm
plus?
improving. I would give myself a pretty, maybe you should probably ask my wife that question, but I would say right now I'm doing about a B plus.
Okay.
I'm still pretty busy clinically.
Yeah.
And, academically trying to stay busy as well. 15, 20 years ago, from trying to find the balance, I was probably a C minus with focusing, which was good for my work life. I did develop and learn and did the things from my professional career, which were quite beneficial. But, looking back, I probably should have spent a bit more time at home. I chat with my kids about it and they say, no, Dad, you were there. You came to the ball games and did all of that. But when I look back on it, I said, I might not have been there as much as I would have wanted. Sometimes not being able to sit down and, help them with their homework some nights. So those types of things. So I take more time now to spend with my wife and go out to dinner. And when I get invited to a meeting now, I usually don't just fly in the day of the meeting and fly out as soon as I can. I'll take a few days ahead of time and bring her along. Now that's getting older and more mature, and the kids
and no young kids at home.
Yeah, exactly. They're old kids now. Yeah. So it, life changes, but I've taken, I think, advantage of that. And I still could fly in and fly out. But now as I said, I take a couple of extra days and, enjoy the place where I went, or I'm invited. So, I very frequently tell the story, meetings are held in Chicago, and I had been to Chicago 15 or 20 times. And then one day when I'm sitting on the tarmac at O'Hare, I'm thinking, I've never been to Chicago.
Right,
because you would go, you'd fly in, you'd either stay at the airport hotel or go downtown. You'd sit in the meetings or speak at the meetings and learn and all of those types of things. go right back to the airport and fly home. And so one trip I decided I'm just going to take the architectural tour on the Chicago River, and it was one of the best experiences. So that's why I try now. I'll do a little bike tour of the city or something like that, just to try to get to know the place I'm going to.
Last time we were in Chicago for the AUA, I said, let me go out for a run. And I don't even have the right watch to know with a GPS to know where I'm going. I just started running. I see signs, Soldier Field this way. Oh, keep going, Soldier Field. My God, I'm right in front of Soldier Field, like one of the oldest stadiums in the NFL. They have a Walter Payton statue. I said, oh my God, this is amazing. You know, it was one of the best experiences I've had in Chicago. Like, you have been there many times, and sometimes you don't know the city because you're in and out. Don't worry, this year's in Vegas, so you can bring your wife and see a couple of shows in Vegas in May.
Already planned.
I've looked at you and watched you from afar, as I said, in conferences for about 15 years. Yeah, about 15 years. You seem to look healthier to me now than you looked back then. I don't know if you are healthier. I know you look healthier, but you look amazing. You look healthier. You look slimmer. Your skin looks healthier. Is that by design? Is that because you've done things differently? You take better care of yourself? What happened?
I do. You know, I learned, unfortunately, my parents, as people get older, they started to get ill. And both my parents had very high cholesterol levels. My dad, at a relatively young age, had a pretty large heart attack that he fortunately survived. Basically, every male on his side of the family had cardiovascular disease. And, you know, he had a brother in his 40s who died of a heart attack. He had a heart attack in his mid 50s. So I started to get concerned about my health. And so I consciously tried to improve my lifestyle and change my diet and started to exercise.
Our next amazing sponsor is XY Wellness, a company I know a little bit about as co-founder and medical director of the company. XY Wellness is a company to help men renew, rebuild, and reclaim their health, their bodies, after a prostate cancer diagnosis. XY Wellness is a lifestyle company that helps provide a no-nonsense roadmap to health and wellness in men after they are diagnosed with prostate cancer. The hope with our program and what we see with many of our members is that men after prostate cancer tend to thrive, not only survive, through our program. To learn more about XY Wellness and its roadmap, please visit the link below in the show note.
And bought a scale so I could know how much I weigh. And
is it a scale that talks to you? A patient said, look, I got this scale that tells you 195. Yeah. And he says, it's good because it tells you hearing it has a more of an effect and motivational effect. So does your yell at you in the morning?
I would yell back at it if it didn't give me the right number.
You.
Well, not quite, but no. So I do not have a talking scale, but I weigh myself every morning. Yeah. That's one of the first things I do when I get up in the morning. I weigh myself and make sure that I'm on the right track. Yeah. I have a narrow window that I want to be in. I try to exercise most days. Some days I don't, but most days I do. And I do watch what I eat. And
so you take better care of yourself now than you did 15 years ago, you'd say?
Oh, goodness, yes.
Yeah. It's obvious to me as one in this kind of lifestyle field, and just looking at, I always say, be careful being chairman. When you become chairman of a department, you start looking bigger, older, and the aging factor kicks in really hard.
Well, one day my wife said to me, she goes, your tummy's entering the room before you do. And that was a bit of an eye-opener to me. I thought I was in relatively fair shape. I wouldn't say good shape, but when she told me that, I'm not sure if she was trying to be humorous, but I think she was making a point, and I took it to heart. Yeah,
It's always, in terms of communication, we're talking about before, when a patient they go see their physician, there's messages and signals coming from the physician that without them even opening their mouth. So if they look unhealthy, overweight, I just think it's a wrong message. We're in healthcare. This is still called healthcare. Whether you're a surgeon, it's still called healthcare. And I think it's very important to look the part. So I admire those of you that look the part and look as healthy and, slim, energetic, the way and taking the time, which I know it's not easy. Certainly early on, you have to kind of prove yourself and so forth. I've certainly been there, but no, it's admirable. So that's why I wanted to have that conversation in terms of, I knew you were doing something.
yeah, thanks. Yeah, I lost about 20 pounds.
Yeah, that's about right.
And, it's one of there was a book I read, I forget the author, but it was called Body for Life, basically.
Mhm.
And, it gave you an exercise routine and a diet routine, and
Mhm.
that, you just have to, get into the routine of doing it. And I don't do that plan anymore. I sort of morphed it into something else.
Mhm.
But it, for me, the hardest part is getting up and doing it. And as
Getting
soon
out
as
the
I get
door.
up and do it, I'm very pleased that
Yeah.
I did. But, there's some days where it's a little harder than the others. And, I'll hit my snooze button and then I'll start feeling guilty, and then I'll get up. But it's, it's a process. It's,
I'm glad you're saying that, because these are the same issues that everyone has. People think I don't have those issues, and I absolutely have the same issues. I love food. I love food that sometimes is not that healthy. I'm Cuban. There's a cultural element to the type of foods that we eat. James, when I first started this health thing, it was over 20 years ago, and I went all in, like the raw food, 100% all in. And my parents live in Florida, and I went right to, and remember, always typical Cuban food. Sometimes it could be healthy, and sometimes not so much. So I go and tell my mom, she's making the typical food, white rice and beans. I'm only eating brown rice at the time. Are the black beans organic, Mom? Did you add garlic? Oh, that's too much salt. In the yuca, right, which is, it's okay, it's a starchy food, but it could be healthy. She adds bacon and all kinds of things. So I said, Mom, I can't eat. That didn't go well. That didn't go well.
I didn't
She
think
screamed at me and, get, if you're going to do it, get out of here. Get out of my face. She was insulted. And actually that taught me a lesson. Now, I worked in restaurants through school, and I always looked and observed how people ate. Taught me a lesson. Food, there's a lot of elements to food that people just think that, well, we just eat. No, we eat for many reasons. And sometimes it brings people together.
Yes.
And one thing I know, I mean, I've read every research paper on diet. I mean, everyone, I can even cite it, right? I'm really versed on the literature. I tell you what, and then I've done many of them. I'll tell you that, and this is good for the audience to hear because they're struggling with exercise. I never want to make someone so neurotic about their diet, which I did initially in my career, so that then they are missing the point altogether and not spending good times with their loved ones. So then what is the benefit of eating this strict diet? So that you live longer, better, slimmer? Okay, so then when you have that health, what are you going to do? Isn't it to eventually spend more quality time with loved ones? So sometimes those in the field miss the point altogether and put these diets together that they're just not, or too restrictive. Same with exercise. What you said is everyone's problem, an issue and challenge. Getting up in the morning. No one says after they've gotten up, they went to exercise and oh, that's the worst idea. Why did I do that? No one ever says that. It's always, oh, thank God I did that. I feel better mentally, and all these things. And it's great to hear that coming from you. And I always want to, present it that way with my own challenges with it, because it's true. Bodybuilders that I know, runners they run marathons. Pete Carroll, colleague, is a runner, hardcore runner,
He
probably 50 miles a week still. He and his brother Bill.
right.
And same issues. I've had the conversation with him. It's like, yeah, I sometimes have, I'm achy, and I just put on my sneakers, and I just don't want to think about it. I just go. So that's pretty good. Let's talk about prostate cancer. Why don't we talk about prostate cancer a little bit?
Sure. Why not?
In this day and age, there's so many options, James. It used to be easier. Radiation or surgery, you pick. Now is like, I spoke to Dr. Aday, on other experts, Arvin George, focal therapies. Like, within focal therapies, there's like 5 options. How do you choose? How can I be, if I'm the patient, an active participant in this decision making where either things sound either too good or too gloomy in terms of my decisions after my diagnosis? And I know it depends on grade and so forth, but just an overview. Like, what are your thoughts? You've been in the field for a while. What are your thoughts on that? Do we have too many options?
No, I think that that's one of the things that I mentioned when I chat with patients. I try to make it a series of decision points. And so that each decision is not, oh, I have to think about all the different treatment options and I'm not sure. So when I go through this with a patient, or when I'm reviewing charts to give an opinion, the first thing I say is the patient a good candidate for active surveillance? I mean, first, do no harm is still at the top of the list. And if the patient is a reasonable candidate for active surveillance, Gleason score 6, almost regardless of volume these days, meaning numbers of biopsies which contain cancer, and if their MRI looks relatively reasonable, I encourage them to at least think about active surveillance. And some patients are resistant to the whole concept of watching a cancer, and that's a conversation you have with the patient. What are you afraid of? Give them a little bit of data in terms of, well, what do we see with active surveillance? No benefit from surgery, no benefit from radiation therapy, only decrements in quality of life. So the first decision point is, am I a candidate for active surveillance or not? If you are, great. Let's talk about active surveillance in its entirety. If active surveillance isn't the right choice, then we say, what is the least amount of treatment that will be beneficial to you? Now, we don't have to think about the 5 different methods of doing focal therapy. The first is, are you a candidate for focal therapy? And then if the answer is yes, then we can go into some of the nuances about, well, why would cryotherapy be better in this situation or not, HIFU, etc., and go through the information as to why, with a cancer that's in this particular part of the prostate, I would recommend this particular energy source. So if they're not a candidate for focal therapy and they're still recommended to have treatment, then the conversation is between surgery and radiation therapy typically. And what goes into that conversation is, well, what are you most concerned about?
From a curative perspective, James, the only reason I go to Twitter, or known as X, is because there's really great colleagues. They're putting up good things,
mm-hmm.
and high quality, actually, papers and citations. My understanding is, if you're a candidate for surgery and you're a candidate for radiation, from a curative perspective, typically there's no difference.
And that's what I tell patients. I say that from the best of our information that we have, there are no direct comparative studies, but the best studies that we can do, that the outcomes between surgery and radiation therapy are similar. You can't say one is better than the other. Then it comes down to burden of treatment. And I think the conversation is different if it's surgery versus radiation therapy compared to surgery versus radiation plus hormonal therapy, because the burden of treatment is substantially increased by the hormonal therapy. So when I chat with patients, all things being similar, it's someone in their mid 60s. They have a favorable intermediate risk prostate cancer. They're recommended to have a whole gland treatment. I mean, it's hard to argue against good radiation therapy. It's not operative, so you don't have to go through all the physical aspects of going through surgery. There's no incontinence. The sexual function impact is less, I think, with radiation alone compared to surgery, even with good nerve sparing, because the impacts of radiation therapy don't happen in the operating room, they happen down the road. So there's a sort of a buffer period where patients receiving radiation therapy do quite well. So I think unless someone has a lot of obstructive symptoms where radiation therapy might not be great, if they have a very large prostate and they're talking about using hormonal therapy to downsize them, or they have a higher risk cancer where they're talking about using hormonal therapy to improve cancer outcomes, I think radiation versus surgery in the general patient that we see, it's a very reasonable strategy to manage patients with prostate cancer. It's not everyone needs surgery.
What I'm not a surgeon. I think the audience knows, I'm not a surgeon. I have to say I am super impressed with the fact that I just don't remember the last time I've seen a patient who, post surgery, who's had urinary incontinence. I don't remember the last time. Am I in a homogenous setting? Because I don't only see NYU patients. I see patients from Sloan and sometimes patients from anywhere in New York City, or they fly in. Or are you guys getting that much better? I just really, it could be maybe recently a gentleman in Colorado that, he's wearing 8 pads a day. Before that, it's been years. What's happening? How is that? Is it the robot? What's happening?
Don't think it's the robot. Might be. Techniques improve over time, but it's still not perfect. I guess it depends on when you're seeing them. If you see folks right after surgery, I mean, most patients are experiencing some degree of urinary incontinence, absolutely. And it takes, on average, a few months to improve. And, overall continence rates, meaning beyond a year, are fairly good. They're not 100%, not at all, but they're fairly good. And, some of the technical improvements, and it's related to the robot. Yeah, I'll give it that, in terms of trying to spare different types of tissue and do different things to try to not disrupt the normal anatomy. That has, I think, improved time to continence. I think overall continence rates were still fairly good. So I think where we're getting better at, which is a good quality of life issue, is people are getting continent quicker. But there are patients that, I have them in my practice. I wish I was better. There are patients that don't recover continence completely. And we've gotten better, but it's not perfect.
Yeah. And I'm online, I'm in platforms and forums, and I see less complaints, not zero, as you said, but a lot less complaints about urinary incontinence. Sexual function after surgery, there again, look, the way I kind of, this is, spoken to Mulhall and who's in your group and other experts in the field. If they're, I say if they're 9 out of 10, 8 out of 10 and higher before surgery, no diabetes, no metabolic disease, and they go to a good surgeon, which maybe, again, many other patients I see go to good surgeons, they tend to regain their sexual function, maybe without sometimes even the injections, just with a little Cialis, a little Viagra, and they tend to gain their erections just fine, it seems like to me. So there again, something's happening. I believe the data may say 40-50% erectile function that's regained, I guess, on average, I guess, or maybe that's high.
It depends on a few factors.
Mm-hmm.
Patient age is critical.
Mm-hmm.
40-year-olds do much better than 50-year-olds, etc. As you pointed out, baseline erectile function. If someone has, 10 out of 10 erections, they're going to do better than someone who's 7 out of 10 or relying mostly on one of the pills to be sexually active. And then the third thing, and this is a shift, because we're no longer operating on low-risk patients who were the best patients to do, complete bilateral nerve sparing on. We're now moving towards operating on much higher risk patients, and they're higher risk because they have bigger cancers. And those bigger cancers are at higher risk for being outside the prostate. And if cancers are outside the prostate, bilateral nerve sparing is not always the right approach. So it kind of works a little bit both ways. If you have a younger patient with normal erections who has a prostate cancer which doesn't have extra prostatic extension, then yes, we can do very good bilateral nerve sparing. Most of those men will recover erections. Most do not recover back to their baseline, and most will be using a pill like Viagra, and it takes time to recover. But I think we're going to see a shift in that. The best patients to preserve erectile function on are patients we shouldn't be operating on. So I think our data will actually get worse, not because we're worse surgeons, but because we're now operating on patients who aren't great candidates for bilateral nerve sparing.
Right. And these are patients typically with higher Gleason scores, you say, 8 and 9s perhaps?
Yeah, so we stopped operating on the 6s.
Yeah.
We don't operate on some, not all. I mean, some of the Gleason 3 + 4 = 7s that are of low volume pattern 4 that have a relatively normal MRI, those patients we're now using active surveillance for. Focal therapy has taken some more of the patients appropriately, and quality of life is better with focal therapy. And surgery is now moving to the realm of higher risk cancers. And so, those patients don't do as well with radiation either, because it's radiation plus hormonal therapy and all of the things that go along with hormonal therapy. But,
so your results on paper may not look so great anymore.
Correct. So
back in the 90s, and in the 90s, the result, wow, this surgeon, 99% curative rate, 99%, improvement in, well, how many Gleason 6 were treated back then, right?
Correct.
So it's all relative to that, right?
It is, absolutely. Yeah. So, and you can't, the one thing, and you brought up lots of the subtle aspects appropriately, someone has diabetes. They're not going to do as well as an age-matched male that doesn't have diabetes. So, if a surgeon says, well, my patients achieve erectile function 80%, I'm making the number up, 80% of the time, it's like, well, who are you operating on? It can't be 80%.
Exactly.
So if I'm sitting in front, the best we can do in someone over the age of 70 surgically, even if they have reasonable erectile function prior to surgery, it's only about 50 to 60% of those men will recover erections adequate for intercourse with a pill. Mm-hmm. And that's a consideration. Some patients will prioritize functionality, and that will help them make a decision regarding what management strategy is best for them.
The younger surgeons have no idea how to perform an open prostatectomy anymore. They're trained with robotic primarily. Correct. Is that an issue? Is there ever a situation? I know there used to be in the early days of robotic, but now, 2024, Is there a situation perhaps that can happen where you're doing a robotic surgery? It's like, oh, guys, we need to, this needs to be an open. Where now the younger surgeon may not be have the ability to do the procedure.
Right. Fortunately, we're getting much better at minimally invasive surgery, and the times we need to do or think we need to do open surgery are becoming less and less. Now, I have a lot of gray hair, so I've done a lot of open.
That's why I asked, by the way.
I've done a lot of open surgery, and at Memorial we do around 1,000 radical prostatectomies a year for the group. I do less than 10 now open prostatectomies a year, and I do them all at Memorial.
Why would you do it at all?
Pardon?
Why would you do an open prostatectomy at all?
We would call it a hostile abdomen. So
that's that is so kind.
Yes. So what I mean by that is someone has had, and I'll give you the most recent one I did, which was a few months ago, perforated diverticular abscess.
I see.
Had to have a colostomy, had to go back in and have the colostomy closed, ended up with an abscess that needed to be drained. The incision that he had developed a hernia. He had a huge sheet of mesh placed. And none of the people doing robotic surgery, including myself, wanted to operate on that abdomen. And fortunately, there was enough room down low where we traditionally do open surgery, and it went very well. But it's a unique thing now. Looking at, and I'm biased because I'm old enough to have lived through the world of open surgery, the difference is blood loss, which is significantly lower with robotic surgery, and less pain. And for me, those were enough to transition from doing open surgery exclusively to doing robotic surgery essentially exclusively. It's better for the patient. Now, we argue about, is it a better for continence, erectile function? Is it a better cancer operation? In my heart of hearts, I don't think it is robotically. I mean, people argue about that, and that's their opinion. That's great. But I think the main thing is we get patients back on their feet. They don't have to use as many narcotic pain pills, which we know is bad. They can be up and mobile more quickly, which we know is good. And they get out of the hospital back to their families quicker. All good things. That's reason enough to do robotics.
When you said hostile abdomen, I actually was thinking, because I know back in the day, if they were too hefty, if their abdominal area was a bit too big, there was concerns about doing robotic. And actually, that's what I thought you meant, not
No. I mean, we have operated on patients, and I'm sure there's many surgeons out there that have operated on patients with higher BMIs. Actually, robotics. No. The only concern we have is when robotic surgery is performed, as you know, we put the patient head down, which is called the Trendelenburg position. And if they're very large, sometimes that pushes on their thoracic cavity, so the anesthesiologist can't ventilate them well. Rarely that results in we can't do the operation that way. And then those patients have the option probably for radiation therapy, or if they really wanted surgery, we can do surgery on a larger person, but again, more higher risk of infection, higher risk of complications, and those types of things. But as long as they don't have, and it's rare these days, as long as they don't have problems with being in that Trendelenburg position, robotics can get one down to the area much better, safer than open surgery. Because
one of the things I do that I'm very happy that I do and proud of the work I do in that regard is when they see me and they see me what I call for the peri-surgical holistic approach, And so they see me and we start doing pelvic exercises before. So I think
Correct.
there's benefit there to kind of
Yep.
strengthen the external urethral sphincter before the surgery. And the guys that have a little bit of a belly, I said, look, if you give me 4 weeks, we can lose 1 to 2 inches in 4 weeks. And so I get them prepared and their body ready. That does several things. Makes it easier on the surgeon, but it gets the patient involved and proactive in their own wellness and outcome. And there's a psychological element there that is remarkable. So I'm hoping how we can get this type of approach everywhere. I guess 10-year studies, a study it would be required. But I think that that approach just is a win-win.
Oh, I completely agree with you, because my hope is that prostate cancer is in the rearview mirror. Now, I'm not 100% cure rates for sure, but the goal is that prostate cancer will not be the health concern that the patient has. It will be other things, limiting diabetes,
Right.
cardiovascular health,
Right.
mental health.
Right.
All of those things benefit from a good lifestyle. And a good lifestyle doesn't have to be challenging. As you mentioned, the easiest way to have someone fail is to tell them, you can't eat, you can't.
Don't
You
do.
say,
Don't.
these
don't.
are the things. Yeah, it's a positive thing. You can do all of these things. You can eat whatever foods you want. Just you have to know about the calories. So if you want to have a piece of cake, just don't make it's not a wedge. It's a piece. And you don't have
and enjoy
seconds.
it and guilt.
And enjoy,
One
and
of
I
the
do
first
that all the time.
The first Dr. Gio rule on eating well is the very first rule. There's 12. The very first rule is never eat anything with guilt.
Right. So one of the, and I don't so jokingly say this, is the reason I exercise is because I like desserts. And so, and I just stopped taking, the whole box of cookies, and now I portion control.
You just eat one row at a time.
Yeah. I mean, you've seen Oreos. Those rows didn't last very long. But no, I'll instead of eating out of the packet, I now put a couple on a plate. Right. And so there's my portion control, and I enjoy them immensely.
Absolutely.
Yeah.
Absolutely.
And, like exercise, you're not going to end up, running 20 miles a day. You just make reasonable goals, and, it took years to put the weight on. So give yourself a break. You're not going to take it off in a week or two.
And enjoy if you give it enough time, some people think, and it's true, there's long-term gratification. We all want instant gratification. Man, I'm doing this. It hurts. This hurts for later. Give it time. If you give it enough time, you do get instant gratification. You
Absolutely.
start after that run for the rest of the day, not just after that run, you feel amazing. You feel sharper. You have more energy. So if you give it time, I say about 3 weeks of consistency, by the 4th week, you start getting some instant gratification.
I completely agree with you. Yeah. I mean, it's always hard to, when I've had times where I wasn't able to exercise for several weeks and I sort of lost it a little bit, and then I had to get back into it, and the aches and pains are there that used to not be there. That's what keeps me going. It's like, I know they're not going to last forever. That's just getting back into it. Yeah. And then the benefit, the endorphins or whatever, just being happy that you've accomplished something.
Yeah.
And, you're doing something healthy for yourself, and, you're there for your family too. So you're doing something for your family and your friends. They want you around, hopefully. And yeah, some days, yes, some days, no, but right. Most days, yes.
Make sure that your kids are, doing well, so that they don't need you to, go away, so that you can have your inheritance and things like that. I guess that some families have to deal with. I hope I don't. Where are we going with prostate cancer? Where do you see the future 10, 20 years, AI? I always say, so I've been in the OR several times with surgeons. I'm amazed. I say this all the time. I'm amazed with what you guys do. I think it's art. I don't know if you just take it for granted after your 5,000th prostatectomy is like, okay, this is just what I do. It is art to remove this gland robotically. You're about 12 feet away from the patient with these sticks, and you're going in there, great visual, and you remove this thing and just reconnect the urethra to the bladder. It's art, in my opinion. I've been 20 years. Doesn't cease to amaze me. You're 12 feet away. Can you be 100 feet away? Can you be 1,000 feet away? Can you be
sure,
20,000 feet away?
Oh, that's been done. I mean, remote surgery is, one of the original thoughts with robotics was that it would allow surgeons during a war to be in a very safe place while someone was there with this contraption, and you could take care of the injured soldier. That probably wasn't the best thought, because most trauma doesn't require a robot. It requires someone there taking care of folks. But yes, I mean, remote surgery is something that's feasible. I think one of the concerns is, can it be hacked? And what's the security of the system in terms of if a surgeon is having to do something remotely and you're using telemedicine or telesurgery, are there safety concerns? So it can be done. And, will it be used more in the future? I'm not sure. I think that, it's sometimes it's a little safer, I think, for the patient to travel a little bit than, to do something along those lines. But it's certainly feasible. And, the use of robotics is just going to increase. And one will imagine that much surgery will ultimately be done not by humans. I mean, we may have to program the robot to do what we want it to do, but ultimately it's going to be able to do it. Color the cancer green, use these intraoperative things that we're looking at in terms of staining nerves a particular color, staining the cancer and prostate a particular color, and the robot will just cut between the colors and do it that way. I mean, it's not so far-fetched these days. AI we're seeing being used in radiology, pathology, you can imagine dermatology. You plug in your information, a robot kiosk, similar to how you order food today. If you go to those types of places, I don't, but if you go to McDonald's, you tap stuff into a kiosk and your order comes up. You can tap stuff into a computer, Watson and those types of things, and they'll come up with your differential diagnosis and tell you what you need to do. I think those types of triage things, an AI instrument looking at an x-ray and saying that's normal, or I'm not so sure about that, and then having the human backup to say, okay, these are the subtle things about it. I think that's where we're headed. And it's a scary time in some ways, but I think it's a very exciting time. There'll always be a need for humans. I think that the personal aspect of healthcare, I don't think can be replaced by a robot, at least.
But maybe the training in medicine needs to make the adjustments as well, so that one of the things that the experts say is look, AI will not be able to tell stories. It won't be able to inspire people and hit emotional, do comedy and when you look at what AI won't do, AI won't be able to communicate in a certain way to patients. It may say facts or you're not a candidate for this, you're a candidate for this. Delivering that information in a certain way, which goes back to our initial conversation, which with how you communicate to your patients, with how Bafar communicates with his patients. That should be in the medical school system and that should be taught. Little things like this, the human element of being a healthcare practitioner, it's going to be everything, I think.
Yeah, I agree with you. I think that, perhaps AI will free the doctor up to have more time than we currently have in some medical institutions. It's very regimented. You have X number of minutes, you need to see this many patients, and you cannot stray from this path. Whereas AI may take some of the data collection and some of that and take it off the doctor's plate. And so now the doc can sit with you, or a nurse practitioner, a physician's assistant, a healthcare provider can then sit with the patient and have a conversation, a discussion about, that was all the information. These were the options that were presented to you. Now, what do you think about those options? How will that impact you? And so that will be a good thing. Perhaps it will give us more time to spend with the patient rather than, sort of popping in and popping out.
Good stuff. Dr. James Eastham, Memorial Sloan Kettering, one of the best institutions. We are a little bit upset that you guys are number one on the U.S. News Report, and and NYU is number two. You noticed that, right?
Well, we've been number one 2 years in a row, as I wink. I think if we were a sports team, they'd call that back to back. But
except that you're not a real urology department, so we're scratching our heads. It was like they're a cancer institution. It's not a
not so. So we have a very large benign group. We have a voiding function and reconstructive urology group. We have a male sexual health group. So it's not just cancer.
That's right.
I know.
I am. Well, first of all, I feel like I've been the luckiest person in the world. Here is this unconventional doctor working in conventional settings for 20 years, first at Columbia, now at NYU for 15 years. My boss, Herb Lepore, has been amazing to me, and I hope that I've been as amazing to the department. And to have you guys down the block, 30, 40 blocks away, not that I go there for much, but just to know that our proximity is so close. And I tell patients, like, this is the reason why people come from all over the world to New York City to get their prostate checked. Globally, people come because it's just really top of the line medical treatments and approaches that is hard to find in other places. I think, call me biased, but I talk to people, I listen to people, I know what's happening everywhere. So it's such an honor and a pleasure. And then again, you're not only with you. I said, well, if you see Dr. Eastham, you don't have to worry about it. Ladone, Bafar, really top of the line. And I'm really impressed with what you guys have done and what you continue to do. So good luck, and continue the good work.
Well, thank you. And right back at you. You're at a great institution. I've had the good fortune of getting to know Dr. Lepore a bit, and you do have a great boss. He's a wonderful, number one, wonderful person.
Yeah.
Just great. And number two, obviously an outstanding surgeon and, a thought leader. I mean, he's morphed into, focal therapy and active surveillance and all of those types of things when, back in the day, he was he was an open prostatectomy whiz, talented surgeon. And, he's developed a different type of practice now and is outstanding at it. So you have a great boss.
Thank you. Dr. Eastham, final words, and where can people find you?
So I'm easy to find. I'm at Memorial Sloan Kettering and easy to get a hold of. I think they'll list my email and the like with the podcast.
If that's okay with you, we will, by the way, if it's okay.
That's fine. Yeah, I have no troubles with that. The final word is, I think, focus on your health. It doesn't take a lot of change. It takes some, but once you've made the changes and incorporate them into your lifestyle, it becomes, I don't want to say easy, but it certainly becomes beneficial to you. And, doing a little exercise, not trying, I'll never run a marathon. I can tell you that. That's not on my list of things to do, right. But certainly, being active and doing a bit of exercise,
Are you playing
changing.
pickleball? Did you
Oh
go into
God, have you
pickleball
talked to my
craze?
wife? Oh God, she wants me to. No, I haven't started pickleball yet, but I know I will. I'll probably get one of those paddles at Christmas. But no, I haven't started that. I mean, my wife is very fit. She encourages
Awesome.
me, and she goes to the gym all the time and is very, very healthy. And I'm very lucky to have her in my life because, when I put that extra cookie on my plate, she's there to remind me not to.
Yeah.
And so, but yes,
Slap
I
it right
will
out
get
of your
into
hands.
pickleball shortly.
Well, keep me posted on that. That may be a family activity with our daughters are 20 and 19. They're kind of into it. And it's like, maybe that could be one of the family activities that we do. So we'll share notes.
Yeah, indeed.
Thanks so much for
Um,
being on, Dr. Eastham. And thank you everyone for watching, for listening. This was amazing for me. I hope it was as amazing for you as it was for me to have one of the greats in prostate cancer, Dr. James East. Stay tuned for more. We continue to bring out great information, ultimately so that you could be proactive and you are well informed to make better decisions about your health and to have a better conversation at your next doctor's visit. So that's what we're here for. Both natural, Western, Eastern, medical, all the best of the best. So thanks for listening. Don't forget to subscribe and like and make comments. I look at all the comments. I can't respond to all, but I look at all of them. All the best. Dr. Gio here signing off. All the best to you. Much love. Thanks for tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.